Hi everyone, and thank you for joining today. Before we begin, there are a few housekeeping items that I would like to address. All attendee lines will be muted throughout the presentation. We will address questions at the end of the webinar. If you have a question, you can type it into the Q&A box, which you can find in the black control panel located at the top or bottom of your screen. And lastly, this presentation will be recorded and it will be distributed to all attendees early next week. Today's topic is Consolidation in Home Healthcare and Hospice, Key Transaction Considerations. Today's speakers include Kevin Palamara, Managing Director, and Jake Vesely, Senior Analyst from Provident Healthcare Partners. And from Health Group LLC, we have Ted Cuppett, Director. I will now turn it over to Kevin to give a brief introduction on Provident.
Thank you very much, and thank you everyone for joining us this afternoon or this morning, depending on where you're joining us throughout the country. As Gina mentioned, I am Kevin Palamara. I'm a Managing Director at Provident Healthcare Partners in Boston, and I'm being joined this afternoon by my colleague Jake Vesely, who collectively spends a great amount of his time working with me in the areas of post-acute care, including Medicare, home health, hospice, and personal care. Just want to start here with a little background for those of you who may not be familiar with Provident, although I know many of you are who have registered for today's conference. We're an investment banking firm headquartered in Boston, or at least we are when we're not in the middle of a pandemic. Most of us are spread throughout the state of Massachusetts today in our homes, working at home like many of you probably are as well. We've been around for 22 years. We are entirely focused on the healthcare landscape. And predominantly within providers and service groups. We have spent a considerable amount of our time historically working within home health and hospice, which is what we're going to talk about this afternoon. I've been with the firm now for 19 years and have a great deal of experience working with many of the groups you see listed here below. That's just kind of a sampling of some of the folks we've been, honored to work with over the years, whether they were clients of ours on the sell side or some of our colleagues that we've had the pleasure of closing deals with within the home health and hospice marketplace. I'll take it to the next slide here so that Ted can introduce himself as well.
Thanks so much. The health group was actually formed in 2010. A little bit background on myself. I've been involved with home health agencies since 1979. I'm going to tell my age a little bit. Hospices since the mid-1980s when the Medicare benefit was put in place. Prior to forming the health group, I was the hospice and home health niche leader for Dixon Hughes Goodman. And we actually operate out of two separate companies. Basically, the Gray Griffith and Mays facet is basically our CPA practice, which provides all those services that you would traditionally think of reaching out to a CPA for, with a strong emphasis on healthcare. While the health group is largely our consulting practice that focuses in on the cost reporting and reimbursement related services, Medicare enrollment, a tremendous amount of Hospice Cap liability work, merger acquisition assistance, and a lot of organizational consulting. The other thing that is nice because of the time period that we've been serving hospices and home health is we have a vast array of other providers that we're not a formalized network, but we're pretty much very comfortable making referrals for whatever those services may be that we may not directly provide. With that, I turn it back over to Jake and Kevin.
Thank you very much, Ted. And again, I really appreciate you joining us this afternoon. I know we've been involved in working together on some transaction work lately, and Ted and his group are highly sought after and work with many of the leading consolidators in the sector and a lot of smaller regional groups as well. So again, appreciate Ted lending his voice to the conversation this afternoon. On the next slide, we're just going to talk about again some of the key drivers here of the activity that we're seeing in home health and hospice. And I will say that for purposes of today's discussion, we're going to focus really on the Medicare heavy side, the Medicare side of things, which really includes skilled home health and hospice care. We do significant work within the Medicaid arena as well. We'll touch upon that, and some of these dynamics are very applicable to the consolidation that we've seen in personal care as well. But again, as you can see here, the activity has been fairly significant just this year, and even as we work through COVID, which Jake is going to talk to on the next slide. We really haven't seen things slow down. We've seen continued activity right through January through July. Now, obviously, in the second quarter with the pandemic, some of that has slowed down a bit. But again, I think what we're seeing here is the trend on the bottom right-hand corner. I would say hospice continues to be the most sought-after area within the post-acute care sector. We're going to talk about some of the drivers of why that's occurring. Personal care, which is typically the Medicaid type services, still has very significant interest, just nothing is really where hospice is right now. And then on the skilled home healthcare side, again, I think they're seeing some headwinds, as many of you know, kind of dealing with PDGM, the review choice demonstration, and just some of the reimbursement challenges you've seen over the years, although we do really expect to see Medicare home health starting to pick up with some larger scale acquisitions as we shift and move it to the end of this year into 2021. In terms of some of the macro tailwinds that you're seeing, some of them are pretty common sense. Obviously, you look at the demographics and the acceleration of growth of that kind of 75-plus-year-old population, the folks that are eligible for hospice and home health care, the increased utilization of hospice, and I think the education that's being provided, that's really driving folks to the end of life care setting. Both of these areas are hugely fragmented. The top 10 players in both home health and hospice probably only account for 15 to 25% of the overall market. There is still, a ton of regional and multi-regional players out there that have not gone through a process. And again, I think there's a lot of blue sky in terms of, consolidation activity. We're going to talk a bit about private equity activity. I know that there's many of you on the line this afternoon that are involved in private equity and probably looking for either a platform in one of these areas, or maybe have your own platform and are kind of considering what to do over the next few years. But private equity consolidation, along with some of the new entrants to the sectors, has really created a very robust atmosphere for M&A. We're going to talk a little bit as well about Medicare Advantage potentially coming into play here as we move into 2021 for the hospice benefit. And again, I think that'll really help bolster growth as well. And I would just tell you, as somebody who's very active in the space and has a lot of networks, I would tell you that there are going to be some very large scale acquisitions announced over the next quarter or two. In more in the hospice space, but there's going to be some big things on the horizon. Obviously, I think the biggest transactions we've seen effectively this year is the AseraCare deal with the Medicis, and really the last truly large home health transaction was probably the Alacare deal with Encompass as we kind of go back to late 2019. Some of you are probably wondering kind of how COVID has impacted things here. As we move to the next slide, Jake can kind of walk you through what we've seen in the market with our clients and what we've been hearing from groups, whether they're buyers or groups looking at potentially selling.
Thanks, Kevin. As Kevin mentioned, a lot of groups are wondering how COVID has affected home health and hospice M&A activity and subsequently valuations. And, honestly, it really hasn't, for a number of reasons that we'll cover below. Provident is currently working on several home health and hospice engagements in various stages of the transaction cycle. And, in these processes, we really haven't seen any decrease in the amount of investor interest, and the valuations, remain extremely strong. They're just in line with what we were seeing pre-COVID. And, I think this is due to a number of reasons. First off, from a financial perspective, we haven't seen as great of an impact to home health or hospice operations compared to what we've seen in some other areas of healthcare. And, there may have even been some positive trends for the sector, as some of the institutionalized settings were starting to attempt to push people to receive care in the home or, outside of the, large group settings to ensure that, the spread of COVID-19 is reduced amongst the elderly population. And additionally, groups have been taking advantage of the telehealth options that CMS has made available to ensure patients, still have the access to the care they need. Overall, as we saw on the last slide, strategics have continued to deploy capital to continue their M&A strategies. We think this is because of a few things. First of all, it's one of the most accretive and quickest ways to expand market share within their existing geographies and to enter into new markets. And, additionally, there's still a ton of capital or dry powder out there that they're looking to deploy. And, this has remained an attractive area of investment despite what we're seeing in some of the other areas of healthcare. I think that the strategic M&A activity was evident earlier this year when Amedisys acquired a Saracare hospice. I think this was pretty reflective of the continued strategic interest in this space despite what's going on. We've also routinely spoken with the major strategics and public acquirers, and all voice a commitment to continue pursuing their M&A initiatives despite some of the challenges presented by COVID. And on the private equity side, private equity groups have remained extremely active with bolt-on M&A activity, and also, those that are looking for new platforms, especially on the hospice side. When you think about the home health side of things, we have seen a slight decline in home health M&A activity, but we think this is likely still lingering from the uncertainty around PDGM rather than buyers avoiding acquisition due to COVID. Now that we have a better understanding of PDGM and we can more accurately model out what future cash flows will look like in the new model, we're expecting to see a significant increase in M&A activity for the Medicare home health segment in the remainder of 2020 and throughout 2021. And on the next slide, we'll discuss the current investor landscape in the post-acute care space.
Thank you very much, Jake. On the next couple of slides, we're going to talk about the evolution of the industry in terms of consolidation and new entrants that have come into the fray really over the past 2 years, but I think we've really seen this develop over the past 5 years. And what are some of the dynamics at play, and why is Humana entering home health and hospice in a big way, and what are the drivers there? And I think as you look at this slide here, I would probably start by focusing on the middle column. Over the last few years, we've just seen obviously some mega mergers in the payer environment. We've seen some very large regional consolidation of Medicare Advantage plans as well. And I think that, the fact that we're going to see Medicare Advantage become a player within the hospice environment, and the fact that I think groups like Humana are really trying to capture the full continuum of care, really the legacy that came on board with what Kindred was trying to do prior to that deal, are the key drivers behind all of that. And I think nobody's been doing that more so than our friends over at Humana over the past 2 years by bringing in, at least through a joint venture where they have significant ownership with Kindred at home, and then right around the same time, bringing Curo and Larry Graham and his team into the fold, and becoming really overnight, one of, if not the biggest players, in the post-acute care world. And so why are they looking at doing that? When a group like Optum obviously took a step back, they sold their hospice division a few years ago, and they've kind of put their bet on the primary care market and on the physician model. And Humana has said, look, we're going to look at this huge population of Medicare eligible Medicare Advantage patients that we have, a huge patient population that we can capture, and try to bring these individuals from the clinical setting to the less costly home setting. And to some extent, it allows them to have, better control, over, their patient population. Obviously, they're not only looking at this for the home health and the hospice line, they're looking at their larger business line, and looking at their risk scores and looking at other factors that are important for their bottom line as, predominantly a group that focuses on, the Medicare market, and the Medicare Advantage marketplace. So we've seen Curo now not only do the Curo deal, they did the Kindred deal. They've gone so far as to bring in the pharmacy benefits side by acquiring the largest PBM in Clara, focused on that hospice marketplace. So they not only have a full continuum of post-acute care, they really are developing a full continuum of end-of-life care. And for those of you that are building up larger platforms, that's probably a good sign as you think about, exit strategies down the line. The other one I want to talk about here quickly is the emergence of, something we really saw, when the home health group started moving into hospice, which is a very natural shift. But now what we're seeing is groups just expanding service lines and doing that in a pretty dramatic fashion. I mean, you think about the BrightSpring and PharMerica merger, and just think about all of the service lines that they offer now. I mean, they basically are nuts to bolts, everything on the service line, the pharmacy side, the benefit side, really bringing it all under one roof. The other interesting dynamic we're starting to see now, we've seen Elara bring together 3 very diverse organizations, with National and Great Lakes and the Jordan folks, and really develop a Medicare, Medicaid focused home care and hospice model. And then more recently, we've seen our friends at Addus Healthcare make a pretty dramatic move into the hospice arena with a few acquisitions, most notably Hospice Partners of America. You're going to see them expanding service lines, and they're going to be looking, and the reason they're doing that is they're looking at crossover opportunities in their key markets. They're not just doing this to buy a hospice. These groups are looking at where is our core patient base for our Medicaid population, and can we find strategic acquisitions that overlay into those markets? Very similar to what we saw happen with the Amedisys and Gentivas of the world, going back 4 or 5 years when they started moving more aggressively into hospice. They'd focus initially on those markets where they had a very strong core of home healthcare patients. If we go to the next slide here, we'll talk about potential strategies for individuals who might be considering an exit and what that might look like. Again, I've been doing this for about 19 years, and really, like I said, going back 5 to 10 years ago, everybody was pretty well siloed in terms of consolidation. If you were a Medicare home health provider, you're picking up the phone and calling Amedisys, Gentiva, LHC, Almost Family. There wasn't a lot of diversity in what you were doing. There was a few private equity consolidators at that time, but it wasn't a hugely, broad, opportunity to kind of go out. Same thing on the hospice side. You'd call Vitas, VistaCare, Odyssey, some of those legacy groups that are no longer with us. And the same thing in Medicare. You'd pick up the phone, you'd call ResCare, Addus, or one of those big consolidators. So the good news is, I guess, for those of you on the phone today that are thinking about an exit, you've got a lot of options. The bad news is, I guess, if you're a consolidator on the phone today, what I'm saying is you have a lot of competition, and the likelihood of you being able to come in at lower valuations is going to be pretty difficult right now, especially, in the hospice environment. And we expect this trend to continue, certainly as we move into 2021. I expect that most of the large groups out there over the next couple of years are going to look a lot like, what Kindred and Elara and what Addus is trying to put together. They're going to be covering Medicare. They're going to be covering Medicaid. I think you're even going to see some of these groups moving into pediatrics. And you might actually see some of the large pediatric consolidators moving more heavily into the adult side of things. And I think we're going to start to see the evolution where groups do bring in some of these ancillary services as well, kind of like we saw with BrightSpring, sort of like definitely like we saw with Enclara coming on board with Humana. And what it really does for groups is it just presents an opportunity. If you're a seller who says, I want to get out, for 100%, there's plenty of options to do that. If you're a seller who says, man, I just really don't, I don't like the reputation of certain groups, and I like to find a group where I can cash out 100%, but I can retain my autonomy, and my nurses won't be mad with me, and my employees will be happy. You have that option as well. And then you have a very strong option as well with the private equity community, where you can go and sell a majority position of your agency or a minority position of your agency, retain control, stay on board in your current position, and just get some additional capital behind you. So again, it is a very advantageous time to be out there on the marketplace, looking at your options. They are aplenty, and there's a lot of good groups out there. And a lot of good options for groups in terms of finding a home for your agency. And I think we'll just go on to the next slide here.
So one of the most common questions we get is, what makes certain home health or hospice assets more attractive than another to private equity or to buyers in general? So what we've listed here are a few key components that increase valuation in these transactions and that would separate groups as true platform opportunities. So first of all, when you think as we transition to a value-based care environment, groups that have diverse service lines and the ability to show cost savings through their outcomes are going to command a premium multiple in the marketplace. But to accomplish this requires pretty significant investment in company infrastructure and especially on the IT side. Another area that really separates groups is having a strong management team. So do you have a CEO? Do you have a CFO? Have you made the necessary investments into your management team to be able to scale the company to double or triple in size without the need for significantly more investment to the management team? Another area is, the ability to retain caregiver talent. One of the biggest issues in the industry right now is retention and clinical turnover. So groups that can demonstrate a lower turnover rate will be more highly coveted amongst their peers, in a transaction process. Another key area is geographic density. So we find that sometimes groups try to expand, quickly into other states to try to cover a larger footprint rather than building density within their geography. And when you think about private equity establishing a platform or an existing platform looking for a regional expansion play, they're going to put more value on geographic density rather than, thinly spread assets throughout multiple states. And lastly, and what I think is probably the most important is, does the business have the size and scale to become a true platform and to support future growth? So, ultimately size will drive valuation, and it's important that groups have a sizable EBITDA base to be able to garner private equity interest as a standalone platform. Overall, I think given the consolidation activity we've seen throughout the past few years, there's a limited number of groups remaining that can qualify as a true platform based on the criteria above. And as a result, there'll be a tremendous amount of competition and increased valuations for these organizations, in a deal process if they do qualify as a true platform. The next slide, we're going to discuss a few key transaction considerations.
Yeah, thank you very much, Jake. And I think here on the next slide, I think these are just, for folks that might be, on the webinar today and it might be in, considering something in the next, 6, 12, 18 months. As I mentioned on a couple of slides ago, the really good thing here about the marketplace, really for home health and for hospice is, there's all these considerations you have when you're selling your business or recapping your business. And, you're in an environment today where you can be afforded, many different options, and hopefully, we can check the box on all 6 of your most important needs here. But again, we come across folks that have a motivation in many cases, they might be looking to exit. They might just say, look, I'd like to find an exit. Ideally, it would not be with these, maybe 2 or 3 groups, but, I would like to transition out. And I think you need to think about, from that perspective, you think about the strength of your existing management team, maybe the folks that are not, shareholders that might be sticking with the business. I think that you need to make sure that as you're considering your exit, that if you, the owner or a husband and wife owner are going through a process, if you're a key driver of the business and the relationships and the referrals, you just really need to keep those types of things in mind, because when a buyer is coming in and completing a transaction, this will all be uncovered in due diligence. And the ideal scenario is one in which there's a pretty seamless handoff, to the buyer in a transaction, whether they're buying into a completely new territory, they want to maintain all that business, or if they're buying into a market where it's more of a tuck-in. They again want to make sure it's as seamless as possible, and the business they acquire, the purchase price they acquired, all sticks around, at least, the vast majority of that, through the closing. And again, I think, you need to think realistically about your time horizon in a process. If you're not willing to stick around for, a year to 3 years or 5 years, you just need to be honest with yourself and with groups out there. That'll be a determining factor as well, and where you land. And again, I think, Jake talked about the platform capabilities of groups. You really need to think about, what is your corporate infrastructure? How much can you grow the business with the existing resources, today? And then again, risk tolerance. We have a lot of folks that are younger that we work with that, really don't want to sell much. I mean, they'd like to sell maybe 50 to 51% interest in their organization, maintain a big chunk of the business moving forward, typically with private equity. And again, that's an option as well. I think you just need to understand the pros and cons of doing that as well. So we have one more slide here, and I'll let Jake kind of wrap up our presentation and then let Ted go through his.
Yes. So a lot of groups, ahead of a transaction process, groups wonder how should they prepare for this? And we really like to think of things in 3 buckets. So strategic considerations, operational considerations, and financial considerations. From a strategic standpoint, what are the key growth opportunities available for the organization? Before going to market, groups really have to sit down and think about what are the avenues for growth, what are things that we can do within our market that would make us a more attractive asset for investors. Another key consideration is the organization able to compete for management and caregiver talent with its peers? If the answer is yes, then this is definitely something that we would look to highlight to investors and would be viewed in a very positive light. But if the answer is no, then maybe it makes sense to run a more strategic focus process where you would stand to benefit from leveraging a larger organization's resources to become more competitive in this regard. Another one, can the organization show data on outcomes? Have you made the necessary investment into your IT systems to be able to easily show cost reductions and a higher quality of care to payers? With the transition to a value-based care world, this is going to become increasingly important in the coming years. The next is some operational considerations. So, does the team have bandwidth to evaluate partners in an orderly and efficient format? A transaction process takes a lot of time, and there's a large time commitment required from management. So it's important that groups have the time and bandwidth to undergo these processes before beginning them. Some other items are items such as corporate documents, leases, articles of incorporation, and payer contracts readily accessible. The due diligence process is very strenuous, so it's important to have these appropriate documents readily available before beginning a process to ensure you aren't delaying things as you approach due diligence. And lastly, on the operational side is, can the organization pull unit level economic detail from their EMR for investors to evaluate the operational statistics of the business? So quality of earnings firms will require this to conduct their analysis of the revenue and earnings of the business. So it's important to connect with your EMR provider to ensure that this information will be readily available, before you start a transaction process. And lastly are the financial considerations. So does the organization keep its financials organized appropriately to evaluate trends by location and service line? Again, this is something that buyers are going to need to see before appropriately valuing a business. Another area is, what will be the impact of converting from a cash basis accounting to an accrual basis? Generally, all these transactions are done on an accrual basis, so you want to look at what the change could look like. And generally, for a growing business, this will be a good thing, but you do want to evaluate that prior to going to market. And then finally, what are the key add backs and adjustments that need to be made to the financial statements to reflect the true go-forward cash flows to the business? So something that we run into a lot on the home health and hospice transactions that we advise on are adjustments to EBITDA based on length of stay or potentially cap liabilities. And this is done so in order to accurately portray what the sustainable cash flows to the business are. And this can be something that's pretty tricky to do internally. So particularly for hospice providers, we always recommend engaging a group like the health group or another similar industry consultant that can conduct the appropriate analysis and cap analysis to ensure that you're ahead of this before you go out to market and into a diligence process. And with that, I'll turn it over to Ted to talk about what he's seeing on his end in the transaction processes and overall in the industry.
Thanks so much. I'm not going to talk a lot about this. This is a lot of repeat of what has already been discussed by Jake and Kevin. A couple points, though, that I think are important, especially if you're a potential seller and you're, for any particular reason, and that is, you know what creates the value. And then, we've got our revenue streams, and we're really looking for consistency and diversity so that we're not necessarily too reliant on one source of revenue or another when it comes to referral places where the patients are coming from. I think that as far as when we look at management, I think one thing that's extremely clear at this point in time because of COVID-19 is if you've got a strong management team, it's going to show up in the financials and everything else if someone is looking at you as a potential target at this point in time. How you came through COVID-19 and those things that occurred, they're going to be clear. There wasn't a lot said about risk management, but everybody knows about risk management in all sectors of what you do, whether that's clinical or in fact, even Medicare enrollment now and human resources. And two other points here. One is that don't always think that strong, from our standpoint, don't always think that a large revenue growth is necessarily to your advantage, especially when it comes to valuing a deal. When we're looking at transactions, most of the time after the transaction or while the transaction's being consummated, not on the front side, we see that valuations tend to be stronger if you're in some kind of a normalcy of revenue growth. The same way with margins between revenues and direct expenses. You may have a very, very high margin, but that may not necessarily end up helping you in an acquisition price because of the fact that you're falling outside of some sense of normalcy. And what is creating that large margin may, in fact, impose a risk someplace else. And then, of course, I like to mention financial statements. Being an accountant, it's really important. If you believe that you are potentially headed down the track of being a target, you really need to beef up on those financial reporting processes. Don't wait to convert from a cash to accrual basis. There's no reason. Home health agencies and hospices are preparing cost reports on an annual basis. At a minimum, you have those numbers on an accrual basis if someone who's doing your cost report knows what they're doing. So there's really no excuse for not turning and starting to develop a history of those historical financial statements, which can do a lot for you, especially when someone is looking at you with limited information on the front side before they begin any kind of an intense due diligence. So you might get a much clearer picture of where potentially the deal could be priced. Going on, take a little look at the revenue drivers. And when I talk about revenue drivers, I'm talking about gross and net. And Jake and Kevin both talked about outcomes and looking at outcomes and how important that's going to be going forward. What we're looking at here are some of the traditional things that you, as a potential target, should be looking at. The buyers are definitely going to look at them. So you should be tracking this stuff in the form of a history so that you know what is happening inside your organization. And that's if you're a home health agency, you're looking at episodic information and history of that episodic information. You're looking at costs on a per visit, cost on that episode basis. And all this information has got to get to the point that was mentioned about the fact that one of the reasons why we don't see from our side as much activity on the home health is assessing that PDGM impact. And of course, as an override to everything is COVID-19. And as we go through this a little bit further, we're going to talk about some of the specifics that we think buyers and sellers should specifically be looking at with regard to activities that are happening as a result of the public health emergency. Now, looking at the same kind of things for hospices, we're looking at, of course, we mentioned CAP and we're going to talk a little bit more about CAP, but we're looking at admission characteristics. We know right now that the prevalence of all those admissions are coming from the Medicare program, soon to be a lot of them coming from Medicare Advantage. But we got to have a good understanding of what are our costs per visit and what's driving those costs per visits. What are our costs per episode, which of course is being derived by the visits as well as the length of those episodes per period. And understanding that daily census by really looking at average length of stays in lots of ways. People throw out average length of stay terms when that number can be calculated in so many different ways. From our standpoint, we really like to look at 3 lengths of stay. And the first is, of course, our deceased patients. We have a true length of stay when we're dealing with patients from the point in time that they were admitted into the hospice through the period of time that they have died. We like to watch that average length of stay for patients on census because, of course, that number will be much higher than what your average length of stay for all your patients is because the short terms go in and out and the long terms, of course, don't turn as quick. And that is also a very good indication as to whether or not you might potentially have a CAP problem if you don't know it or you're headed toward a CAP problem. Because of the height of that number, we can generally gauge it off of an average and lifetime length of stay to tell you how to monitor that number and how to use that number for purposes of setting targets to get you under the cap or know when you potentially might hit the cap. And of course, one thing that doesn't get a lot of conversation and hasn't got a lot of conversation up until the last couple of years, in fact, CMS started using the term probably about 2.5 years ago, and that's lifetime length of stay. Lifetime length of stay drives CAP. It is the driver. And lifetime length of stay encompasses that average length of stay for all your patients for the entire term that they've been on hospice, whether they were served during an earlier period of time and got discharged and now have come back. That lifetime length of stay encompasses both of those episodic periods. It also encompasses the time and the days during which a patient may have been served by another hospice, because those are all extremely relevant to the cap. And actually, that's a very easy number to calculate. And I probably should have put something in here, and I'm sorry I didn't. But that data is readily available to you, can be computed in just a matter of minutes if you know where to go get that data, because it's in that Medicare database. Next slide. We want to talk a little bit about some of the COVID-19 considerations. And while I think the comments that were made by Jake and Kevin are right on target, especially when we're looking at hospice, I don't know that COVID-19 is really going to have any impact to a great extent on how strong the value for hospice providers are. However, there are going to be COVID-19 impacts, short-term impacts that we're dealing with now, long-term impacts. Even after COVID-19, we're going to have COVID-19 impacts that are going to the future. There's no question there are impacts on quality of earnings and how those computations are going to be made as a result of the due diligence process. And there's also COVID-19 implications that are going to affect the purchase agreement in other ways, causing companies to liquidate liabilities at the time of closing or to escrow monies potentially for other liabilities. And all of those things at least need to get some serious consideration. So I'm going to talk a little bit about some of these issues. And the first one is PPP loans and loan forgiveness. Loan forgiveness is not generally going to be a problem now for sure, since they have taken what was an 8-week period of time to utilize the funds and they extended it to the 24 weeks. And any liability, of course, that would result if there is one, which will be far and few between, and probably only caused if there's some FTE reductions that don't get overcome. But if there is a liability, it's going to reside with the entity. And so it's not going to pass to a provider number in an acquisition where it's an asset kind of a purchase. But that liability is going to be there for the entity itself. Income and the associated expenses to achieve the forgiveness, they must be considered in the adjusted EBITDA, but the impact is going to be relatively minimal in the fact that the only thing we really have to recognize here is any non-recurring incremental kind of expenses that may have got charged back to the against the PPP loan for forgiveness. There is an overlap issue with provider relief funding, and that really needs to be minimized. For example, of course, we are telling all of our clients with PPP loans we're not going to apply forgiveness to the last minute. And when we do apply for that forgiveness, we're going to make sure that we're not including any expenses that could be charged back against provider relief funds against that forgiveness. For example, when the PPP loan program first came out, we had a short period of time in which salaries and wages basically had to be 75% of the amount for forgiveness, and as a result, a lot of providers may have been giving out special bonuses or pay add-ons related to COVID-19, and that also potentially helped them to ensure that the PPP loan got forgiven. Well, now that the period's been extended, that's not necessary, and those bonuses can be charged against the provider relief funds. So we definitely don't want to use those monies as part of the forgiveness for the PPP loan when we can apply them against the provider relief funds. We want to make sure and use our expenses as wisely as possible to make sure that we've used up those funds. There is an issue that came up with reimbursement recover, and we hope it's going to go to bed and be gone, but CMS released information to critical access hospitals and rural health clinics that PPP loan forgiveness would be used to offset reimbursable costs because they're cost-based reimbursed, so that no two sources were paying for the same cost. Now, information has come out since then, although relatively informal, that in fact none of the PPP money as well as provider relief funds would be used to offset reimbursable costs to the extent that it would cause any payback. However, we want to watch that close, and everybody on this call is going to want to watch this issue close because, I've just been around too long. Until I see something finalized, I always have to play it cautious when it comes to CMS and what they may do, whether it's reimbursement or anything else, very frankly. So we just want to keep our eye on that very closely. Next, we want to talk about the relief funding. Of course, the relief funding was provided for two things. One, lost revenues that the providers may have incurred, and there are providers out there who are going to have no problem justifying 100% of the relief funding from lost revenues. Not necessarily in the home health and the hospice space, but definitely in some other healthcare spaces. And for COVID-19 expenses that they could directly relate to the public health emergency, with the understanding that every patient is a potential COVID-19 patient. So pretty much what we were dealing with is cost associated with the health emergency itself. Originally, the reporting was supposed to be done on a quarterly basis and was going to only be applicable to providers that reached the threshold of $150,000 in relief funding. Now that's changed such that now all providers are going to report. The reporting mechanism is going to come out supposedly by HHS here in the month of August, with reporting it basically two different year-end periods. The first period being for those providers that believe they've justified 100% of the use of the relief funds, and the second period for those who have to report the use but haven't utilized 100%. And then the final reporting is, at this point in time, scheduled to occur in the summer of 2021. And of course, we've had a lot of focus on this. It's taken a lot of our time dealing with our clients with regard to what we believe potentially will be chargeable back against those relief funds. The question continuously comes up, will they have to be repaid? And we're working under the assumption that the answer is yes. To be conservative, there's still in my heart this piece that says I think they're going to have problems, assuming that the providers did everything right in coming back against them down the road for repayments of these particular monies. But in any kind of an acquisition, for sure, and from any other standpoint, I think you have to work under the assumption that if you can't justify the use of the provider relief funds for those expenses and lost revenues, you better be in a position to be repaid back. And if that doesn't have to happen, then great. Now, there are some issues with regard to the provider relief funds, though, that specifically relate to transactions that have already occurred and could occur. And that is the fact that we're dealing off of very bad information from HHS. It's very conflicting. You can read one paragraph which contradicts another. However, in the Q&A specifically, they talk about buyers and sellers. And you'll see that this is right here in the slide itself. And what they're basically saying is this is a taxpayer identification funding. So, for example, if an asset acquisition were to occur after a provider has received the funding, that funding can't be used by the acquiring entity. The COVID-19 expenses and lost revenues through the date of acquisition would be determined, and any remaining funds would, based on the Q&A, have to be returned. Now, what they have done recently, so you know, is they just came out with the fact that they're now accepting applications from providers who may not have had money because a change of ownership did occur, dealing exactly with the quotation that is previously shown up above. So if they went through that application, they went through a chow, theoretically weren't entitled to those monies, they can now make application for the monies that are remaining, and they'll have through August the 28th to make that application. It's also available for those providers who may have, for whatever reason, returned the original monies and not accepted them. The revenues and expenses have to be considered in the determination of adjusted EBIT, in my mind, because of the fact that we're going to have this group, this batch of money that relates to lost revenue, which is really not going to be reflected in the quality of earnings. It's going to be difficult to use that revenue, of course, and there are no offsetting expenses to be applied against that. However, when we look at the expenses that have been funded by the relief funds, there are those that are truly one-time, and those that are going to be recurring, because a lot of activities got diverted. They weren't added. An example would be administrative time by current personnel who now are spending time related to COVID-19 safety or whatever the case would be. That time, if documented, is going to be, without a doubt, chargeable back against provider relief funds. But that's not an expense that is going to disappear when COVID-19 ends. So looking closely at the expenses that these providers are going to charge against provider relief funds becomes very, very important. And also the fact that this is, in fact, a liability, at least right now, that is associated with the federal identification number and not the provider number, has to come in play when you're dealing with the potential purchase agreements that may result in a particular transaction. Next slide. Advanced payments, that's actually a pretty easy issue in the fact that a lot of organizations, especially home health, not so much hospice, but home health, a lot of home health agencies took advantage of the accelerated advance payments. So they received these funds in advance of being reimbursed, and the advance is being recovered starting 120 days after the issuance of the advance funding. That has not been delayed as of this date. So in many cases, funds are already being withheld, and they're being withheld at 100% of reimbursement. The problem is going to come into play if providers had revenue decline such that at the end of the 200-day recovery period, they haven't paid it all back. At that point in time, a demand for repayment will be issued at the present time by the MAC, and the provider will have to deal with that just like they would any other repayment obligation, with basically 15 days to repay or the development of some kind of a request for an extended repayment schedule or some other way to liquidate that balance. The other COVID evaluation issues that I just want to point out is there are some changes in sites of service that have affected revenue streams for particular providers. And, you know, one of the things that comes to mind that I think is important, as well as the modification of referral streams, is utilization of hospice inpatient units. And during the COVID-19 period, from what we're seeing from our clients, and we have a lot of clients that have inpatient units, is there's been a dramatic shift in, number one, potentially reduced census from what it might have been during pre-COVID-19, and secondly, a piece of increased census as a result of, we'll call it, unsafe home environments, where hospices have moved patients from the home into the inpatient unit, even though they may not be billing for inpatient services. They're billing for routine home care days because of certain particular circumstances in the home. Now, the one nice thing that we're already looking at is the expenditures that are being incurred on behalf of those routine home care patients as being a justifiable, with, I don't think without much difficulty, as an appropriate use of provider relief funds. The other thing that has happened here is that there are changes that have been made that are definitely going to continue post-COVID-19, and Jake and Kevin talked about telehealth, as one. We've got some other new issues that recently came up, and I won't spend a lot of time talking about all the confusion relative to this payroll tax holiday and the executive order that just came out the other day, and what might happen there, as well as tax consequences on the particular entities with regard to not only if but when they report taxable income related to PPP loan forgiveness, as well as the provider relief funds, which may in fact be dictated whether the entity is on a cash or accrual basis. Lastly, let's talk a little bit about Hospice Cap, because I know we mentioned it. Try to make this as short as sweet, because we can talk about CAP for hours, at least I can. There are two CAP liabilities of importance when we deal with a transaction, and sometimes it's difficult for the sellers to really get a grasp on this, not so much on the buyers, but the sellers, and that is the fact that we have a current CAP liability, if we have one, and that's determined as of today or date certain. And basically that CAP liability assumptions assumes that every patient on service during the particular CAP year is dead, and of course they're not. So as those patients continue to live, the CAP for any particular provider is going to decline, and if there is a CAP liability, it's going to increase. And in fact, in some cases, you may not have a CAP liability today, but if someone makes an assessment who knows what they're doing, at least they can come up with something reasonable to estimate what that CAP liability may be 1, 2, and 3 years out as the MACs continue to modify those calculations. Of course, CAP liabilities have to be considered in the adjusted EBITDA calculations, of course, which are going to impact value directly. the cap liability needs to be associated by the particular period with which they're dealing, whether it's a fiscal year or a trailing 12. Cap liabilities are going to be assumed by a buyer, pure and simple. They're going to go with the provider number in either an acquisition or any kind of an equity acquisition. There still are two cap methodology out there, streamlined and proportional. We're down to probably 15 to 17% of all providers being on the streamlined method, but what it does is it accelerates the cap itself. It's difficult to get off streamline and go to proportional because of the way the MACs are making the computation, and they're different. Every MAC's different. So if someone believes it's time to make that flip, and everybody eventually will make the flip, but timing is important and the calculation is important so you don't find yourself recognizing a liability that you didn't expect to have. And every time we deal with provider acquisitions, where we have multiple providers involved, it's possible that we have to deal with cap implications, especially if it's a tuck-in or if there's multiple providers serving some kind of common service area, and how patients get moved and providers get terminated and merged in becomes very, very important, and those calculations are very important and they need to be done right. Lastly, and I know we're reaching the limit here, and I'm a little sorry, but it's important. We just want to talk about some of the stuff that's sitting out there in proposed legislation. Will it ever come to fruition? Your guess is as good as mine at this point. But there is additional provider leave funding, especially in the House bill, that's based on a quarterly submission that deals with expenses and a percentage of revenue losses with some specific restrictions. There is a provision in there with an extension of time to repay those advance payments in the House bill, and a reduction of withholdings, but that's going to be irrelevant fairly quickly unless something is done because those withholdings are going to be made. There is in the House bill the allowability of the deductions on the tax return filings for the PPP loan forgiveness. That's become a tax fiasco there, intended to be tax-free, not really tax-free. Special payments. There are special provisions for rural providers for sure. And as Jake and I believe, I can't remember whether it was Jake or Kevin, but as one of them mentioned up front, there's a substantial payment focus on payments to home care providers, home-based providers, including personal care. And there's no question that's going to become, in my mind, a rapidly growing market for potential acquisitions, because more money is going to get funneled into that component of the industry, I'm absolutely certain. There's some other things in there like legislation now to allow hospices to provide respite care in the home, and I think that that's extremely important. That's something that's long overdue, COVID-19 or no COVID-19, frankly. The question there is going to become what kind of cost the hospice has to incur to provide that respite care in the home, because it's not going to be provided in a facility that provided meals and housekeeping and everything else before. And lastly, I'd like to point out that it's going to be very interesting to see how MedPAC assesses all of this information when it looks at future reimbursement rates and what kind of recommendations. We watch MedPAC very closely. Fortunately, Congress doesn't always act quickly on MedPAC's recommendations. However, if you go back and look, what you will find is that MedPAC recommendations, somehow something happens with all those 2 to 3 years after the recommendation. So even though it's not quick, eventually it gets someplace. So we're going to be extremely interested as we get around to the fall and how MedPAC looks at some of these situations. And with that, I know we're right at the end, but hopefully we've got some time for Q&A.
Yeah, I think just, with respect to everybody's time, we'll probably just wrap it up. But all of the presenters' information is displayed on the screen here. So if anybody would like to reach out to Kevin, Jake, or Ted, you can find their email and telephone number, again, right on the screen. You can also direct questions to me, and I can forward them along to the most appropriate person. We appreciate everybody's time this afternoon. Thank you so much for joining.